presenter this morning is Dr. Kaley Gyorfi. So Kaley sent me her bio yesterday, and I was sitting there and put it into ChatGPT and said, rewrite this in the style of a Taylor Swift song. Unfortunately, my voice is a little under the weather, so I can't sing quite as well as Taylor Swift, but the whole thing is a bop, but the chorus particularly so. And so this basically sums up Kaley quite well. Oh, she's a small town girl with big city dreams, chasing stars in the night, or so it seems. Now she's a resident in the land of cheese, but California's calling, whispering in the breeze. Unfortunately, next year she will be leaving us to go to California with a generalist position at Kaiser Permanente in West LA to join her husband, who will be doing additional training in anesthesiology. She joined us here from the University of Wisconsin La Crosse and was in the Wisconsin Academy of Rural Medicine program, which landed her here as part of our rural residency. We've loved having her here, and I've loved hearing Taylor Swift blasting on the labor floor with her, and we welcome her for her grand rounds this morning.
Thanks, Dr. Bizzuto. Okay, I do not have any financial disclosures. However, I do have a bias towards these rural communities, as my entire life so far has been lived in this wonderful state. And the majority of my medical training has involved the rural communities of Wisconsin. Our objectives today include defining what a rural population is, illustrating the rural health disparities in America, illustrating the rural health disparities in Wisconsin, describing current federal and state health initiatives that are aimed at supporting our rural communities, summarizing recent healthcare changes in Wisconsin, and discussing a roadmap of rural healthcare moving forward. So what is rural? We all might have some images in our mind when we think of what rural means. Some people may think of farms. Some people may think of cows on farms. Maybe some think of historic downtown communities. But whatever you are imagining in your head, during the rest of this presentation, I urge you to set aside any bias you may have regarding the life and the disparities people face that live in these areas. Because as we will discuss today, there's so much work to be done to care for these patients and people of rural America. So let's get started. First, we're going to start with some definitions. So the U.S. Census Bureau defines a rural area as a territory outside of urban place, helpful, but they further define that as a population that's greater than 50,000 people. However, the Office of Rural Health helps further define rurality in the healthcare setting to include hospitals located in municipalities that have fewer than 10,000 residents and are 25 or more miles from a population center. With these definitions in place, it's estimated that up to 25% of the US population lives in a rural area. When looking at our state specifically, in the most recent census report, less than 1/3 of our state's population lives in rural areas, or about 1.4 of the 5.7 million people in Wisconsin. Compared to other states in the US, Wisconsin actually ranks among the top 10 states in terms of number of urban places, with 13 designated metropolitan statistical areas. Even though less than 1/3 of Wisconsin's population lives in these rural areas, maps like the one on the left demonstrate just how focused these urban pockets throughout our state are. The dark green areas throughout the state demonstrate an estimated 100% rural population, whereas the tan areas demonstrate a less rural or higher urban population. And of the 72 counties in Wisconsin, 45 of them are considered rural, with the definitions previously mentioned, And those are the dark blue counties on the map on the right. So why does all of this matter? The disparities that the rural population is facing is something that has been studied for many, many years. The CDC estimates that a quarter of the adult US population only practices 4 of the following 5 healthy habits: not smoking, maintaining a normal BMI, regular physical activity, minimal or moderate levels of drinking, or sufficient sleep. All habits that are crucial when thinking about health, leading to overall longevity and decreasing the risk of chronic disease. The rural population is also more likely to die from these following conditions compared to their urban population counterparts, including heart disease, cancers of all type, unintentional injuries, chronic lower respiratory diseases, and/or stroke. I also think it's very important to recognize that the deaths from unintentional injuries, including motor vehicle accidents and opioid overdoses, are 50% higher in the rural areas compared to urban. Additionally, those health disparities listed on the previous slide, the Wisconsin Office of Public Health also reported in their recent demographic publication that rural Wisconsin residents are also more likely to be living with a disability and be living without health insurance compared to their urban counterparts. So then what about OBGYN care specifically? A recent review article published in the American Journal of Public Health performed a nationwide analysis of maternal ICU admissions and maternal mortality. As most of us know, the United States maternal mortality rate continues to climb, despite the US being one of the highest healthcare spenders. However, when comparing maternal mortality rates per 100,000 live births, rural residents throughout the US experience maternal mortality rates of up to almost twice the rate of patients in rural areas, in urban areas. Also, numerous studies completed over the last decade have continued to show a high preterm birth rate for rural patients compared to their urban counterparts, along with increased teen birth rates. When reviewing these disparities, I thought that the teen birth rate was pretty interesting. This figure shows that even though the overall teen birth rate has continued to decline since the late 2000s, as we can see from the darker green line on the screen, the rural community teen birth rates, or the lines seen in dark blue, are declining at a slower pace and continue to be higher compared to their urban counterparts. And similar to data seen with basically all other obstetric issues, generally non-white patient populations are affected at higher rates compared to their white counterparts, which is likely related to the systemic racism that we see basically in all levels of healthcare in the United States still to this day. And this isn't different in any of the rural communities. The graph from the same review article stratified the teen birth rate data by race, which, as you can see, the teen birth rate is higher in each rural population, which is the light blue bars in the graph, but the highest in the Hispanic and non-Hispanic Black populations. A recent review from the Wisconsin Office of Rural Health set out to better understand the obstetric delivery services and workforce in rural Wisconsin hospitals. Critical access hospital designation is given to eligible rural hospitals by Medicare, Medicaid, and is aimed to reduce the financial vulnerability of these hospitals and provide benefits for them providing specific services to their patients. This map created by their team shows the rural critical access hospitals that are highlighted in blue and the rural non-access critical hospitals in orange. And then a survey was sent to these hospitals to better assess the obstetric care that was being provided at these locations. What they found was that 56% of Wisconsin's rural hospitals provide obstetric care of some type. In general, Wisconsin does better than the national average in terms of the number of critical access hospitals that are actually providing obstetric care. This review showed that about 53% of Wisconsin's critical access hospitals in particular provide some obstetric service, whereas this number is approximately 40% nationwide. And from this review, the number of deliveries was also reported from each critical access hospital. And 60% of them have less than 200 births per year, and 10% of them had less than 100 births per year. When thinking about rural obstetric disparities, it's crucial to consider patients' physical distance to a hospital system that provides obstetric care as well. And as the number of hospital closures, and specifically rural hospital closures, has continued to rise, not just in Wisconsin, but throughout the entire US, the distance that patients have to travel to receive care rises as well. This map of Wisconsin on the right was created by the Wisconsin Office of Rural Health and shows the drive time in minutes to an obstetric delivery service. The green on the map demonstrates a 15-minute drive, and the orange demonstrates a 30-minute drive. However, with that being said, we can see that almost a third of Wisconsin's landmass does not live within a 30-minute drive to a hospital that has the capability of delivering a baby. When thinking about travel times to receive obstetric care, we must consider some remote locations or maternity care deserts as well. A maternity care desert is defined as any county without a hospital or birth center offering obstetric care and without any obstetric providers. As of 2021 in Wisconsin, about 15% of the counties here are considered maternity care deserts, which are the lightest counties highlighted above. And when looking at maternity care deserts throughout the United States, the red counties on this map are considered maternity care deserts, and the dark orange counties have low or limited access to maternity care. The March of Dimes 2022 Perry stats estimate that over 2 million patients of childbearing age live in these red maternity care deserts, which include over 1,000 counties throughout the US. And an additional 3.5 million patients of childbearing age live in counties with limited or low access to obstetric care. And when considering these maternity care deserts, it's clear to see that a lack of OB providers in those areas matches nearly perfectly. And the counties that are colored in dark green here represent 0 obstetricians in that county. The U.S. Government Accountability Office shared an analysis of maternal health in rural areas, which was published in fall of 2022, which showed that the overall number of rural hospitals providing obstetric care has continued to decline since the year 2004. They report that nearly half of U.S. counties do not have active obstetric services, similar to the map seen on previous slides. In their analysis, they also report that many of these areas have a majority of low-income and non-white patient populations. This analysis of rural maternal health also discussed with stakeholders what they believed were the most important factors affecting the availability of obstetric services in these rural areas. And the stakeholders ranked Medicaid reimbursement and recruiting and retaining providers to be the biggest factors affecting the availability of obstetric care in rural America. In terms of Medicaid, these reimbursement rates set by states do not cover the full cost of obstetric services, which generally means financial losses for hospitals in rural areas. As we previously discussed, rural Americans are more likely to be uninsured or have state or federal health insurance as well. Data from this report demonstrated that Medicaid covers 50% of births in rural areas versus only about 40% of births in all other areas throughout the US, meaning that these rural hospitals are taking financial hits compared to their hospital counterparts in urban centers. When discussing recruiting and retaining providers in rural areas, it's also important to remember not only OBGYN trained physicians are in shortage, family medicine providers, certified nurse midwives, nurses to staff a labor and delivery unit and operating room, and anesthesiology providers are all key when considering adequate staffing in these rural hospitals. In terms of recruiting and retaining providers, stakeholders listed key factors that are thought to affect providers from wanting to work in rural areas. These include difficulty recruiting younger physicians due to work-life balance concerns, decreased support for newer physicians in smaller communities, and decreased access to resources, which some newer physicians may not be as used to comparing the resources that they had available to them when they were in their residency training. Stakeholders also reported that it's vital for hospital administration to make obstetric care a mission of the hospital, despite the financial and staffing issues that they may have. When that does not happen, this can lead to closures of OB units altogether. And large hospital affiliations often provide financial support to these smaller rural hospitals and clinics. However, sometimes the views of larger corporations may not align with smaller hospital leadership and care providers in these rural communities. So it's important for the smaller hospitals and clinics to have leadership at the forefront in terms of relaying what those community values are and what their needs are when these situations do occur, which seems to be happening more and more frequently. Obstetrics isn't the only care that's affected in rural areas either. So gynecologic care, specifically abortion care and access to gynecologic cancer-directed care is also limited in rural populations. Dr. Caitlin Myers, who is an economics professor in Vermont, published this map showing the patient distance to the nearest abortion provider, comparing the year 2013 on the left and 2023 on the right. Now, clearly, this is confounded by the Dobbs decision a couple years ago. However, both sides really demonstrate that rural areas of the U.S. have had a history of limited access to abortion providers and that the disparity has worsened over the last 10 years. In 2013, it was estimated that less than 1% of the US population was over 200 miles from an abortion provider. And now the patient population is 15% of patients are over 200 miles. When researching access to GYN oncology care, there are numerous studies and reviews showing decreased access to cancer-directed care and increased mortality in the rural population compared to their urban counterparts. Also, patients of the rural population are generally diagnosed at later stages. They're less likely to receive standard of care treatment in rural areas and have an overall worse outcome during their cancer-directed therapy. An article published in the American Society of Clinical Oncology Journal looked at the rural cancer gap, and their review showed that over half of the counties in the US also don't have access to an oncologic provider of any type, which are all of the white counties seen in this map. So as we have heard over the last 10 minutes, access to care is a large factor that leads to health disparities in rural populations. So what are we actually doing about these disparities? So when considering these healthcare disparities that rural communities face, it's important to acknowledge what has been done to try and combat this nationwide problem with rural medical training, along with providing a solid infrastructure in terms of healthcare policy for the future generations of physicians to continue to work in and expand in rural America. One nationwide initiative is to increase the rural experiences to medical students and residents to try and increase workflow into rural areas. The Rural Health Information Hub reported that approximately 45% of rural track medical school graduates will enter a rural practice within 7 years of residency graduation. Research has also shown that increased exposure to rural practice in medical school can increase rural providers. According to 2021 Journal of Rural Health article, over 60% of US medical schools have students that participate in some type of rural health experience, though less than 25% of schools have an actual dedicated rural program or curriculum for their students. And when looking at 3 of the oldest rural track medical school programs in the country, nearly 65% of graduates practice in a rural area, and over half of those providers practice some type of primary care. A recent study published in the Journal of Graduate Medical Education looked to quantify associations between the amount of rural training family medicine residents receive and their subsequent work in rural areas. And what they found was that about 90% of the family medicine residents had no rural training during their residency at all. However, of the residents that did spend time in rural area, those that spent at least 50% of their residency training in a rural community were associated with increased odds of practicing in a rural place. The U.S. Health Resources and Services Administration funded the Rural Residency Planning and Development Program, which is aimed to increase the number of rural residencies throughout the U.S. Currently, there are 45 accredited rural residency programs throughout the U.S. with over 300 residents, and this number is only expected to rise in the next couple of years with nearly 600 ACGME approved resident positions. And with that being said, I just want to take a brief moment to thank Drs. Hartenbach and Spencer for spearheading the nation's first rural OBGYN program, which has sparked regional and national news since its start. Our state also has the Wisconsin Collaborative for Rural GME to continue to improve rural healthcare for rural residents of Wisconsin. And one of their initiatives is to better understand the life of rural residents throughout the state of Wisconsin. And I know you're probably all getting tired of hearing my Midwestern accent this morning, so I'd like to take this time to pause and we'll watch a day in the life of one of their featured residents. Okay. So one main way to assist in the development and rollout of these rural training opportunities is through healthcare policy and grants. In January of 2023, the Centers for Medicare and Medicaid Services awarded 200 of 1,000 new Medicare-funded physician residency slots in order to prioritize hospitals with training programs in areas where the need for additional rural providers was high. And also in July of 2023, the U.S. Department of Health and Human Services awarded close to $11 million to the Rural Residency Planning and Development Program to continue their work on program development throughout the country. In terms of nationwide healthcare policy to help address rural disparities, specifically related to obstetric and gynecology care, the list of programs truly is endless when, trying to summarize what I think are important ones. One program that I came across in my research was the Rural Maternity and Obstetrics Management Strategies program. And this program is aimed to improve maternal care by collecting data on rural obstetric services and then translating that data to help with continuity of care in rural communities, assisting in like remote or telehealth development for rural communities, and then improving financial sustainability for rural hospitals and clinics. And then we have the Improving Access to Maternity Care Act, which Congress passed in 2018 to ensure that National Health Service Corps sends OBGYN trained physicians specifically to areas of need. And then the last federal act we'll discuss is the Preventing Maternal Deaths Act, which was also passed in 2018, which authorizes the CDC to support state and tribal maternal mortality review committees. Wisconsin legislature has recently made important attempts to combat rural healthcare disparities that are seen throughout our state. Just in fiscal year 2023, nearly $4 million in funding was provided specifically to our state to increase access from rural communities and to strengthen rural health networks and also to improve quality improvement projects for critical access hospitals throughout Wisconsin. And the majority of these programs are listed above. However, even with policy changes at the national and state level, it still doesn't protect our patients and hospitals. There's still closures that are happening. In terms of what's happening in our state right now, there's a large hospital system closure in western Wisconsin, which includes Eau Claire, my home city. 2 hospitals and 19 clinics have closed over the last month, including Sacred Heart Hospital in Eau Claire, and St. Joseph's Hospital in Chippewa Valley, which is just 15-20 miles north. The toll that it's taken on the Western Wisconsin community is already outstanding, and with family in that area, it's constant news coverage in terms of like where are these people gonna access care. The loss of services from these hospital closures include a large birthing center, a cancer care area. Specifically, one of the main issues is the emergency room that is now closed, an inpatient adolescent psychiatric unit. That was the only unit for adolescents in western Wisconsin, and dialysis treatment centers. Due to this expected toll that this would kind of place on the neighboring communities, Governor Evers did sign a bill funding $15 million for the western Wisconsin healthcare systems in general, hoping that the open areas or hospitals and clinics can focus on providing urgent care services, mental health services, and OBGYN services for these patients that now have to travel even further to receive the care that they deserve. However, even though closures are happening in some parts of our state, one of our rural residency partners, Western Wisconsin Health, which you guys got to see during that video, has recently expanded their obstetric and surgical services. Their expansion includes increased staff and building of more labor and delivery rooms, along with surgical suites, in an attempt to keep up with the increased demand that their hospital system has seen over the last couple of years, which is only expected to continue to rise after the closures of the Eau Claire and Chippewa Falls hospitals and clinics. So what are we going to do moving forward? In 2023, the CDC established the Office of Rural Health with the new National Center for State, Tribal, Local, and Territorial Public Health Infrastructure and Workforce, and their initiatives are as follows. So they want everywhere rural communities to routinely screen for blood pressure and ensure normal blood pressures. Our QI goal for our QI initiative for their rural clinics, increasing cancer prevention and early detection. And generally this is seen by statewide coalitions such as the Wisconsin Cancer Collaborative is what we have here. Next is improving physical activity, healthy eating, and smoking cessation in communities, along with support for families of patients that have mental, behavioral, or developmental disorders, promoting vehicle safety, and then a large drive is programs to decrease opioid use disorder. As from the beginning of the talk, a lot of the unintentional injuries are a key way to decrease the mortality, specifically in rural populations. In terms of OB specific work from the US government and their accountability office, so efforts must be made to increase reimbursement, specifically to keep obstetric services open, along with increasing telehealth and remote consultations for patients that have transport issues, along with establishing regional partnerships with larger medical centers to assist in high-risk obstetric conditions, while potentially allowing patients to remain at or near their homes, whether that be leading up to delivery or for delivery specifically. Thank you for your attention today. I just want to take this time to thank my husband and family for their support. Doctors Rice and Spencer, who saw potential in me 4 years ago. Doctors Hartenbach and Dr. Kaley, who continue to push the department and residency forward. All the faculty for your mentorship, appreciate it. And co-residents past and present, thank you.
Great job, Kaley. Thank you.
Thanks.
Given your experiences and also your research about these rural health disparities, what do you think is the most impactful thing that we can do from an urban setting to help our rural friends in Wisconsin?
Yeah. I think the things that specifically Wisconsin has done in terms of like medical school and residency training is pretty outstanding. And obviously like funding of those programs takes a while to initiate and then to like continue to either maintain that funding or even grow that funding. But the gap in care is just, it seems like such a large hill or like mountain to climb that seems like it is hard to catch up, right? Like it's when you have, 2,000 to 5,000 expected OB positions that need to be filled throughout the country, and that is only expected to go up. But you only have a handful of programs throughout the country that are, preparing residents specifically for that location. Just the numbers like don't add up. So, I think we are doing a good job, but I think everybody else, the country needs to be doing a better job in terms of preparing medical students and residents for that specific practice. I also think one important factor too is like keeping up those relationships with the rural areas and hospitals and clinics around. I think it's easy for a residency program to have, good relationships with the hospitals that they like send residents to, but there's also a lot of clinics and hospitals around that I think, could benefit from specific like education and up-to-date, grand rounds and M&M and things like that. So I think that's a possibility, like to help those areas that otherwise don't really have access to updated like evidence-based medicine, really.
What's the most important useful skill that you've gained from your rural rotation experiences that you recognize when you're back here in Madison that you might have that others don't as a result? And like looking forward to your new practice in a very urban area, like what are you going to be bringing to that setting that's really special that others can learn from?
Yeah, I do think that the resources available in the smaller hospitals is something that, at a larger institution, you sometimes take for granted. And, even providing obstetric care at a otherwise like, community hospital can be limiting. So imagining that on an even higher level is something that I think that I've learned. And the mindset changes when you're there, right? In terms of like, what do I have available to take care of this person? And if I don't have those things available, or I'm anticipating that I'm going to need X, Y, or Z, and I don't have that, how can I safely get this person where they need to be? Which Dr. Maddie Wetterhahn, touched on her grand rounds last year about like, consults and referrals and obstetric transport and things like that. So, and that's not specific to rural areas, right? Like low resource urban hospitals also have issues in terms of what they have available too. So just taking all that into my next stage.
Take
I
two.
can do fine.
Great presentation. I was just saying that as you were going through the presentation, I saw a lot of parallels between the challenges in rural healthcare compared to global health and practice in lower resource settings in other countries. I've seen just from like exposure and different research that lower and middle income countries make use of kind of non-physician providers and community health workers, just other members of the healthcare team to help fill that gap in the healthcare workforce. I wonder if you've seen kind of parallels to that in the rural healthcare setting as well, and whether there are strategies in addition to rural residency training for physicians, looking at healthcare, like physician extenders versus assistants versus nurse practitioners, community health workers that could be beneficial in this setting.
Yeah, I think the more successful like units that I've seen, whether that be in medical school or residency, have had a pretty strong like community outreach or stakeholders via the clinics, whether that be nurses or just the like actual health system themselves extending into the community. I think that is helpful in two ways. It then lets the hospital and clinic better understand what the community needs in terms of disparities and like can help better identify issues in terms of getting access to healthcare. But then also is kind of like that bridge between the health system and the community itself. So that when or if something does arise, patients do feel comfortable coming to the hospital, because that is a issue in rural America and potentially, what you've seen in global health too, is that some people just wait until it's like the last minute to receive care. So.
Yeah, I've heard a joke, but there's probably serious undertones to this as well, that if you see a farmer come to the ED, that you should be very, very worried
Yes,
because
yeah.
they often don't show up until things get really serious. So
Right,
late
exactly.
presentation to care, certainly, I can imagine is an issue in both settings.
No questions in there. Thanks everyone in the chat.
Great job.
Thank you.
Thank you, everyone.